Thanks so much for joining us today. Welcome to this first webinar in the PBRN Learning Series brought to you by the Agency for Healthcare Quality Research and Quality, AHRQ, and the National Center for Excellence in Primary Care Research, NCEPCR. The webinar today is a panel discussion featuring experienced leaders from three PBRNs. I'm Dr. Jean O'Connor, and my team from Econometrica is supporting AHRQ's PBRN initiative. Next slide, please. We are managing the logistics for this webinar. Before we get started, we wanted to let you know that auto-generated closed captioning is available through Zoom. If you'd like to use that feature, click on the icon in the Zoom toolbar at the bottom of the window. Also on the toolbar, you'll see a Q&A icon. If you have questions for the panelists or need help with Zoom, please use the Q&A function in Zoom. We'll have a segment at the end following the panel discussion to answer submitted questions, time permitting. Finally, we wanted to let you know that this webinar is being recorded and will be posted on AHRQ's website. Next slide. Now, I'd like to introduce Dr. Amy Eden, the Acting Director of AHRQ's National Center for Excellence in Primary Care Research, for some opening remarks. Amy?
Yeah, thank you, Jean. And thank you for the acronyms AHRQ and NCEPCR. So on behalf of AHRQ's NCEPCR, I'm excited to welcome you to the first of 3 offerings designed to share the experiences and work of a whole variety of PBRNs. We hope that these learning events will provide insights and useful information as PBRNs really continue to evolve with the healthcare needs of their communities, but also with the larger structural changes going on in the healthcare system environment. This learning series is just one part of a larger 2-year project that Jean referred to revitalize AHRQ's relationship with the PBRN community. And these other tasks include convening technical expert panel meetings to identify areas of need and to obtain insight regarding strategies for supporting the work of PBRNs. It includes updating and maintaining the PBRN registry, which many of you probably know is a little outdated at the moment, and then making some functional improvements where we can along the way. And finally, creating a report to synthesize the past 10 years of PBRN research, tools, and resources to really start promoting a little bit more cohesively the value and work of PBRNs. I know that many of you in the audience are probably in some way or have been engaged in these activities, and we really thank you for your help as we do this work. So with that, I'll turn it back over to Jean to get started with today's exceptional panel. Thanks.
Thank you, Amy. So during today's panel, we're going to hear them discuss a number of issues that many PBRNs address, which is thinking through infrastructure, funding, their relationships with clinical practices, partnerships with other practice-based research networks, and external investigators and governance. So we're really excited, next slide, to introduce Maureen Boardman. Maureen is going to help facilitate today's panel, and she will lead the discussion. Maureen is the Clinical Research Director of the Northern New England Co-op PBRN, the oldest primary care research network in the country. She's also a clinical assistant professor of the Community and Family Medicine at Dartmouth School of Medicine, and she practices at Little Rivers Healthcare, a federally qualified health center in Vermont. Welcome, Maureen. I'll turn it over to you.
Thank you, Jean. So I have the pleasure of introducing our panelists today. So if we can go to the next slide. So our first panelist is Dr. Michelle Chui. She is associated with the PBRN PearlRx, Wisconsin's pharmacist PBRN, located in Madison, Wisconsin. She's been the faculty director since 2017, and her research interests are medication safety and in the outpatient setting, reducing health disparities in underserved populations. All right. And then our next panelist is Dr. Christy Ledford, PhD, FACH, and her PBRN is HamesNet in Georgia. She's been the director of HamesNet since 2021, research director of the Military Primary Care Research Network from 2014 to 2020. And her research interests are community engagement and community-led research, translational science, dissemination, and primary care workforce development. And lastly, but not least, Dr. Joy Lewis, DO PhD, and her PBN is A.T. Still University School of Osteopathic Medicine in Arizona. Location in Mesa, Arizona, at a federally qualified health centers and at federally qualified health centers across the United States. She founded this PBRN in 2012. Research interest, she founded the National Center for Community Health Research, Research Alliance with the National Association of Community Health Centers, value-based care with an emphasis on social determinants of health for patients and communities served by health centers, implement and evaluate programs with focus on quintuple aim, and community-oriented primary care projects based on CHC and community needs. Always partner with community. All right, and with that, we will start our questions.
I can jump in with the first question. I have it up. What infrastructure have we developed to support our PBRN, and what glue holds the PBRN together? And I'm happy to start, if that's okay.
That's fine. Thank you.
Of course, our PBRN structure is a bit unique because I am part of a new model. It was brand new when we started, of an osteopathic medical school, which A.T. Still University already had a relationship with the National Association of Community Health Centers. And then when our school was started, we started a model where our students were in Mesa, Arizona for their first year of their undergraduate medical education. And then they would go to it started at 10 and grew to 15 community partners sites at community health centers across the country. So we had a built-in structure that was ripe for development of a practice-based research network, in that we have a 1.5 full-time equivalent faculty members at each of our community partner sites across the country. So when I started the PBRN, I reached out to our physicians at the community health centers that we were already partnered with, and told them about the AHRQ and what PBNs were, and asked them to join in. And so that was really the foundation. So I think I had it easier than some others. And we just started with very small projects at CHCs, and we'll get into more of that later.
I can continue with what Joy said. So my PBRN is a pharmacist PBRN in the state of Wisconsin. And it started in 2013, but within the first couple of years, it became quickly known that we had sort of expanded beyond, our abilities, and we really were stagnating. So in 2017, we built a partnership with the State Pharmacy Association in Wisconsin. It's called the Pharmacy Society of Wisconsin. And together we built a 50-50 partnership with the two of us, and then expanded the PBRN to include the entire state of Wisconsin in collaboration with our two other pharmacy schools in the state of Wisconsin. So in terms of the infrastructure, we really work in partnership with the state professional society, and that's really what the glue is that holds us together, because we can take advantage of their listservs, we can take advantage of their annual meetings, their educational offerings, to really support the work that the PBRN is doing. And I'll let Christy continue.
Sure. So for us, it's really important to think about how practice-based research is very different and growing So when I think about the question of infrastructure, first I have to remind myself what my mission is, because every practice-based research network honestly has a different mission. So in the past 3 years, one of the things we've done is really created a tripartite mission that's a little different than it was previously. We're not only focused on clinical practice, we also now have an arm that focuses on community engagement and another arm that focuses on research education. So for us, our infrastructure is inherently intertwined in this mission. We have a little bit of infrastructure that focuses on clinical practice and traditional kind of PBRN ideas. But then we have another arm that works on community engagement and how do we develop questions that matter to the community? How do we partner with the community, engage them in everything we do? And then another infrastructure that's just about the research education, because we're really working on how do we grow and develop learners and clinicians around the state who can continue this work and grow it. So for us, when I think about infrastructure, I have to think about it in those 3 ways. And then I also have to think about, okay, but what is the structure doing? Is it scientific? Is it consulting? Is it mentoring? Is it administrative or logistics? And for us, we've really leaned heavily into a scientific mentoring teaching realm. We don't, as an infrastructure, provide any regulatory infrastructure or budgetary or fiduciary support. So from that way, our infrastructure is a little leaner than I know some PBRNs are. But that helps us at least stay mission-centered.
Thank you all for your answers on that question. So question number 2 is, what resources or funds help to support the infrastructure and the research projects of your PBRN? Christy, do you want to take it?
Sure. Like most everyone out there on the internet today, we're all trying to find a way to fund our work. Here, we certainly rely on 3 different sources of funding. We have internal support. For us, a lot of our success is about we're Georgia's only public medical school. So our dean really supports us in understanding the work we do and advancing the health and well-being of Georgia and its communities. So we have a lot of internal support, not just by word, but also by dollars for our dean. And he supports a lot of our personnel resources, but also our travel funding and our administrative support. Then we have 2 different kinds of external funding. We work with community partners and community foundations. Similarly, along with that mission orientation, the local community foundations, understanding the work we're doing with community engagement, the work we're doing with health around the state, really relying on private dollars, who we got a 4-year infrastructure grant from to help us really grow the network, especially into rural spaces where a lot of work is not being done. We have a mission of a local partner who's interested in that. And then lastly, of course, the more traditional NIH/federal funding. We benefited from a PCORI grant of community engagement, and that really helped grow our community engagement mission. So for that way, we're always trying to keep, I would call it a balanced portfolio to make sure that we are representing both the government, but our community well, and also our local partners. We also rely on resources in terms of internal resources, especially scientifically, in terms of statistical support and library support. We provide those to clinicians around our network, and those are not supported through monies, but through time by those people here at our university, and that's invaluable. I just can't even calculate that benefit to our local clinicians who otherwise don't have library access or any statistical support. So from that way, we have just the whole academic environment is supporting us and is supporting our clinical partners that way.
Thank you, Christy. Michelle, do you want to answer next?
You know, Christy did a really comprehensive answer. I will say that when PearlRx was first developed, we received quite a bit of very generous seed funding from our CTSA. So the UW-Madison CTSA is called ICTR, the Institute for Clinical and Translational Research, and they funded us for a number of years until very recently we lost that funding source. But we're looking for new funding sources all the time in all of the same ways that Christy has mentioned. I will also say one, I wouldn't call it a funding source, but we do charge a little bit of money for researchers to use and leverage the network. And so, you know, we sort of put that in the little kitty for an emergency rainy day fund if we need small supplies or things like that. It's not an onerous amount of money, but we are getting a little bit of money that way as well.
Thank you, Michelle. And Joy?
Thanks. And I agree. Christy and Michelle have both given really great responses that I would echo many of the parts that they mentioned. In particular, the fact that we're mission focused. And I think because of the focus on our mission and it's in alignment with AT Still University, of which we're part of, we too have had significant support from the university. And this comes from our wonderful sponsored programs team. They help with every stage of grant development, from obtaining the grant to executing the grant to doing the paperwork after the grant, which can be a lot of work. We also have a great statistical support team that we can use for our projects, and this is from the university, not directly for the PBRN or the school. And then before I started the PBRN, we had the AT Still Research Institute. It was already in place, and our PBRN and our National Center for Community Health Research, which are really interrelated, are both part of the AT Still Research Institute. So we were able to join that team with really great research professionals and an infrastructure already in place. And from the get-go, we had access to survey tools, to database management. You know, you can say you'll analyze all sorts of data, but then have nowhere to put it. So we had that structure right from the beginning. And then in terms of funding, similar to the other PBRNs, we started off small with smaller projects, really small grants, card studies that could be executed without a lot of dollars. And then we had some internal grants from ATSU, and then grew these to outside grants from the CDC, HRSA. We just finished a 5-year, $2 million primary care training enhancement grant, which was really great for the work of the PBRN and for developing additional PBRN researchers. And a great source of our support for the infrastructure and the funding is our relationship with the National Association of Community Health Research. So we are on a number of projects where they are the primary grant recipient from the CDC, and we are a sub to them. And they have just really tremendous people running their quality center and their research center. And we've been fortunate to partner with them on many projects.
Joy. So now we'll shift focus a little bit away from infrastructure and funding and the next question is about, as an established PBRN, how do you maintain existing relationships with your clinical practices? Joy, do you want to take that one first?
Sure. Thanks. So first off, if a provider who's been working with us in the PBRN calls and asks for something, I try to start with yes, and then find out what it is that's needed. And I think by doing good work, by showing that the work we do is high quality and work that can make a difference in the real world. Sometimes and often our work is not generalizable, but that is purposeful because we're addressing the needs of very specific communities and specific populations that could be left out of other types of research. So for the work to be high quality, it doesn't mean it has to be generalizable, but it still is done in a really sound way using excellent research methods, but excellent quality improvement methods, but focused on that very specific community. Another way is by being respectful of everyone, not just deciding with the CEO or CMO or chief nursing officer that you're going to do a project, but coming in and talking to people who will actually be executing what will be happening. So talk to all the nurses, talk to the front desk, talk to the medical assistants, even the maintenance team, the data team. Don't just assume that you can pull data from an electronic health record, that doesn't, because that costs time and it costs money to do that. So really being respectful of everyone and communicating really well. Another important point is that the practices should never feel used after a project. We don't go in there to write a paper. We go in there to partner with people and to answer important questions that are important to them. Their needs come first. And that has really been the foundation with, I believe, how we've been able to grow, because we never come in and say, we'll solve this for you. Instead, it's, what issues are you facing? And that, I think that's foundational to PBRNs, with just the term practice-based, the practices come first. And then we have a yearly research summit where we meet with the National Association of Community Health Centers, and we've had people from the Bureau of Primary Health Care, from the CDC, from other organizations come and meet with us, and with the whole team from ATSU, even those not primarily focused on the PBRN or the National Center for Community Health Research. And we talk about what are our research on quality improvement priorities, and we try to align projects with those. But again, we don't demand that the projects align, because the projects come from the communities. But we have this open dialogue and are able to touch base on a regular basis. And I think that has really helped us maintain our relationships. Thanks.
Thank you, Joy. Michelle?
Yeah, thanks. So Joy said an awful lot about this. The question, starts with as an established PBRN, but before you get to an established PBRN, you have to build infrastructure and you have to create critical mass. And so actually the shift from growing to sort of sustaining is a completely different skill set. You're engaging people really differently, where you're growing numbers, like trying to get providers to jump on board, trying to get researchers to engage with you to develop projects, to really getting to the point where you have all of these people that are excited about working with you, and then how do you keep them engaged? So I really want to focus on that part of the question, since Joy did such a nice job with, when introducing this question. So I think the first thing is that we have an advisory panel that are individuals who are really well respected. So I think that that's really key, that, you're not the king of your PBRN. You're not the one that's running the show. You're really taking a very humble approach to trying to ensure that you're listening to what the needs are on the ground level. As an academician myself, I'm not, on the ground working with patients. And I want to make sure that the problems that we're trying to address and the projects we're doing are actually very meaningful to both patient care and the providers that are providing patient care. And so strategically thinking about who you want to ask to be on your advisory group, whether that's a board of directors or however you call that, I think is really critical. Like Joy said, where she said they have one meeting in which they engage face-to-face. We also have two meetings that we use in collaboration with our State Pharmacy Association, in which we can use those meetings to recruit participants, disseminate results, conduct a focus group. And so I think that allows providers and members of the PBRN to really show that we're at the front of their brain all the time, that we're engaging with them all the time, that the work is taking place. It's not sort of invisible at the university. They're seeing it all play out. And then last, I want to say that when we work with providers on our project, we must pay them. We require all of our investigators to provide a reasonable, respectful payment for their time. This is not volunteer work in their very busy, burned out work life. We have to respect their time that they're contributing to that. Even if they're gaining value in their own practice or in their patient care, we have to pay them. So I'll stop there.
Thank you, Michelle. And Christy?
Sure. So I don't have a lot to add, but I'll just build on what Joy and Michelle said. I will take a little bit of a turn back, because I don't want to follow Michelle and people think, oh, Christy's at a really well, like it's in good shape. It's super established. I mean, we're definitely growing. So we're taking a step a little bit back. I'll talk about time, travel, and prioritizing communication. So one for us, and I don't know if the people attending the webinar are more community clinicians or if they're more academicians, but the understanding that time is different in those two places. People who live in these academic spaces, those of us who are privileged to have protected time for research, we can, in the middle of the day, read emails, we can, middle of the day, do deep thinking and read literature. But our practicing community clinicians, that's not how their time is spent. So being very aware as you're doing any sort of infrastructure creation or management, that time is different. In my community practices, they don't read email at all. They are busy taking care of patients, and that means that patients are always first. And I say that to them all the time, patients first, always patients before papers, that we're here to help your patients, and that really frames everything that we do. Second, travel. I live in a state that has 159 counties, and I spend a lot of time on the roads, driving in and among those counties. For us, face-to-face time is super important. These are small clinical practices in rural areas, but also suburban areas. They're small clinics. And being there and honestly seeing the life of the community and seeing the life of the patient and seeing the life of the physician, it is hard to explain the problems of health problems in a community unless you see, I can see that the air quality is bad. I can see that the economy is really struggling. I can see how many people are at the grocery store smoking. You know, you feel that in a different way when you spend time in those communities. So for me, travel is super important, and it helps keep it together. I know that's not a privilege everyone has. But for me, I still really value face-to-face time. So we bring ours together once a year, just like Joy and Michelle talked about. But the rest of the year, I spend time actually doing site visits. And the last thing that kind of goes along with that is regular, consistent communication when we're not together. And Joy said, when, you know, a clinician calls, she always says yes first. I'll just add to that. And when a clinician calls, I answer the phone. So it's very important as the PBRN director to have protected space, that when one of those people call me or email me, I can prioritize them. That my dean and my chair have allowed me that if I'm balancing between, I have 6 emails from the dean and I have 1 call from a community clinician, I need to address that community clinician's concern first. And that's super important. And it communicates to our community clinicians that we are investing in them, we are investing in their patients, and that's what matters first to us. It's not that they're an afterthought after all of our responsibilities that we're taking care of here at the medical school.
Thank you very much, Christy, and everyone. Those are very wonderful descriptions of how your PBRN does things. So we have a couple of questions related to payment, and we were going to take these before we kind of change the subject. So one of them, I think, Michelle, is probably directed towards you, but everybody can answer because you were the one who mentioned. How do you determine how much you pay the clinicians?
Thanks. So what we typically do is, so we require some payment of something. So that's the minimum bar. So if we're asking providers to fill out a Qualtrics survey, we tell investigators minimum of $5 Amazon gift card. You must pay them something. You can't expect something for free. Obviously, $5 is really the bottom. We would like them to pay them $20, $25 for the development of a survey. A lot of times we ask our providers to engage in an interview or a focus group for some preliminary pilot data. In that case, we require a minimum of $50 per hour. That's also a low bar as well. We would like to do more, but you know, everyone is constrained by budgets. And so our minimum is sort of $5 for a quick and dirty survey and $50 for a focus group or an interview, and then it goes up from there. So if you want to test out an intervention at your site, then obviously the money goes up. And in those cases, we try to think about personnel time in those sites and how much how much the investigator sort of needs to buy time from a support staff to organize recruitment of patients or whatever the case may be. But that's how we sort of help them, as others have said, how we help them sort of cost out what we think the project is going to cost.
Thank you, Michelle. Joy or Christy, do you have anything to add to Michelle's answer?
That was a great answer. Just one other way we've paid is if, for example, when we did a study working with 3 different health centers in different locations across the country, bringing some concussion education and helping to put some concussion tools into their electronic health record, we gave them money for what they told us would be the time. And it was about even for each health center, how much time it would take for their people to actually do the work to input the tools into the electronic health record. And then for surveying the providers at the health center, we made sure that we offered the survey during one of their large meetings, and we brought food. And so we didn't pay them to take the survey, but at least it was a time that they were already planning to come together. And so we've catered a lot of breakfast and mostly breakfast and lunches at health centers to at least show some appreciation. That's not monetary payment, but it at least showed that we're valuing their time.
I'll add one more that I think is kind of an innovative idea that one of the investigators considered, which was that we didn't have an opportunity to pay anyone. The researcher that was doing this work didn't have funding to do this, but the state pharmacy association really cared about this project. And so what they did was, for individuals who participated, they did a raffle of those individuals to give a guest student membership to a student to the association as an opportunity to engage in continuing education or come to a meeting. And so there's also opportunities to provide sort of in-kind payment as well.
So what I'm about to say is aspirational. We do not currently have a payment model for the practices. We are a very much grass-seeded organization. So anytime we've worked with clinics and there's some sort of, I also call it an exchange, it's been equipment. So they need something and we're able to supply a type of equipment that they don't have. But looking forward, the way we write our grants is we write it so that there is research staff on site at every site. Now I'm going to tell you we have 3 grants under review, and I don't know if that's going to go over or not. But for us, what we're finding, at least in our needs assessments with our clinician partners, is they are so overtasked and overburdened, I can't even buy any of their people's time. So if I said, oh, I've got this grant, I can pay for half of your CNA or half of your RN to help with this study, they're saying to me, no, we absolutely have to have that CNA or that RN to be providing patient care. We'd love for you to do research here, but you got to hire new staff and bring them in because of our workforce shortage. So from that perspective, for us, looking forward, it's more of a workforce multiplication that we're looking to do in terms of enhancing practices more than it is paying, just because our practices in these small rural areas, they don't have staff for us to pay. So it's a problem, but it's a problem we're working to solve.
Thank you very much. So the second question is also related to funding. So the person wants to know if you would be willing to share how much of your budget is funded by your university, percentage rather than dollars. So I don't know if anybody wants to take that one on or not.
I'll say that I would have to really do some back of napkin math just because that's not how we calculate budgets. All of us who are attached to our PBRN are also have other roles. So I would probably have to do some pretty fancy math about what the proportion was. I can tell you that our local university covers time, travel, and administrative support, which is another kind of time. They do not provide, I know some PBRNs provide seed award funding. We don't have that. Some PBRNs provide other kind of funding, like out to the sites. We don't have that. So when we're putting budgets together, it's more about how many clinics do we need to visit this year? How many clinics do we need to build work with? And how much of our faculty time and admin support time will that take? And I would say our university covers 1 to 2 to 3 positions, like 40 to 60%. Does So that's probably about the best I can do in terms of proportionality.
Thank you. Does anybody else want to tackle that question?
Until recently, our CTSA covered 25% of one support staff and 5% of me, which is abysmal. I mean, that's laughable, but that's what I got. You know, there's so much of this is, you know, altruistic work that we care very much about. And so it's still worth it. But when you're asking about funding, it doesn't cover the work that's being done.
Yeah, I also don't have an exact percentage. And I think that over time, the percentage has changed because we've been very successful in recent years in bringing in grant money. So we're more self-sustaining because of that. However, we couldn't have brought in the grant money if we didn't have the support of the university and this tremendous sponsored programs team that I mentioned before, and the whole infrastructure. So I too would have to really sit down and take a look at it. But I think having the relationship with the university, you know, is really important, and having the patience to grow over time and to be willing to start with the smaller projects that don't cost a lot of money, and then build up the resume and then be able to go for the larger grant funded projects is important.
Thank you all for answering those two questions from our audience. Now we'll go back to the other questions. So how does your PBRN identify partnerships for research projects? An example is, you know, have you ever partnered with other PBRNs for a multi-PBRN site or study?
I'm happy to start that answer. You know, as I've mentioned, we have this established relationship with federally qualified health centers across the country, and then this relationship, particularly through the National Center for Community Health Research, with a lot of acronyms, the National Association of Community Health Centers, or NAC. And we work with their research team, their quality improvement and integration team, and then their quality center. And through them, they reach out to primary care associations and health center controlled networks. So we have these partnerships that then spread out to find health centers and others to come in together. And that's one way that we do this. For the smaller projects, it's often through we call them regional directors of medical education. I'd mentioned the 1.5 full-time equivalent faculty at each health center, and we work with them, and then they introduce us to their colleagues. And then what I haven't mentioned yet is that we have our medical students at these community health centers, and from the start of our school, we've had them at these local community partner sites from years 2 through 4 of their undergraduate medical education. And our students do community-oriented primary care projects in their second year. And with these projects, they work with their health center, they work with local communities. Somebody asked a question about work with community-based community healthcare workers, and we have done that. And what we found is health centers are doing all sorts of amazing things, and they have all sorts of really innovative, creative, terrific programs that are meeting the needs of vulnerable populations. And the health centers themselves often lack the human capital to evaluate those programs. So our students over the years have done a tremendous job of partnering with the health centers, following the elements of community-oriented primary care, identifying communities of interest, identifying a problem, developing a program, and analyzing the process and the outcome, or going in and analyzing programs that are already there. And we have some projects that have looked at the effectiveness of community healthcare workers, and we've really been able to make a case for how effective these workers are, and then that can be fed back to the health centers to help support continued funding for the healthcare workers. So that's a number of different ways that we've found partnerships or been able to promote the work and do the work of the PBRN.
I'll just add a little bit more that there's a couple of other pharmacy PBRNs around the country, one in Indiana that we have collaborated with. And there's another one that's multi-state in the South that focuses on rural health. And so we've collaborated some with them. And then within Wisconsin, there is REN, which is the primary care PBRN, which has been around much, much longer than we have. And we've been very fortunate to learn from them and also collaborate with them as well.
Thank you very much. All right. So last question that we have before we open it up to more audience questions. What advice would you give someone regarding PBRN governance? Michelle, do you want to stay on and take this?
Sure, and I think Joy's going to continue on. So governance is the most boring part, the most dreary part of this entire job. But it's something that you must do. What's really important is that your policies and procedures are really transparent, that they're done with stakeholder engagement. Because what you don't want to do is you don't want to make decisions about the appropriateness of one project or another project. You don't want there to be an appearance of favoritism. There's lots of different players in this space, all of which think that they are deserving and important and the most important piece critical to patient care. And so even, how do you design, who do you decide to be on your advisory panel? How do you select a project? How payment is done? How often do you communicate with providers and patients and stakeholders? All of those things need to be worked out. Fortunately, there are, a number of PBRNs that I'm sure will be happy to share with you their documents. There's no point in recreating the wheel, use the templates that are available out there. But I cannot impress upon you enough that spending the time to get this done will save you lots of headaches later on.
Yeah, I think Michelle, that was an excellent answer, and I don't have a lot to add. We have a very similar focus in that you listen first, and I think that's for any leadership position. Communicate clearly, and then I love what you said about transparency, about the policies and procedures, and the notes I had written were, make it clear when something is subject to choice and when it is not. And I think it's actually great parenting advice. It's great department chair advice. It's great academic and other leadership advice, just to always be clear so people know. And I think then they're more satisfied with where you're going moving forward if they didn't have a false belief that something was changeable when it wasn't.
Thank you both for your answers on that question. So now we'd like to turn it over, or I'm going to turn it over to Jean, who is going to ask some of the questions that have come in from the chat.
Yeah, we've gotten some really great questions coming in the chat. One of the questions, we'll try to get to them all, but one of the questions that kind of flows from what you just were discussing is, what are some of the priorities you're hearing from your communities? You talked about listening first, so it's a great question. What are some of the priorities you're hearing?
So I can start with that. So I want to clarify, when we use the word community, we're very particular about that. We differentiate between community members and community clinicians, because those two groups of people often have actually pretty divergent priorities. As we talk to our community members through our community engagement arm, we've just done a project on their priorities, and I can name those easily. Our number 3 priorities are mental health access and healthcare, housing insecurity, and gun violence. Those were not what we expected going in. Those certainly aren't the same kind of thing we'd expect to hear from clinicians. So when we think about what the community's interested, what they're engaging on, and how we're talking to them, that's what we're hearing. At least that's what's coming up to the top right now. When we talk about our clinicians, a little different. They're more interested in, the conditions they take care of. So we did a different process with them. We're mainly family medicine primary care practices. So we hear much more about chronic disease management and prevention. So anything from how do I work on how to better incorporate home blood pressure management into my actual clinical decision making, all the way to we're having a syphilis outbreak in Georgia, and we need to really work on prevention there. So, topics that maybe the literature is not telling us is, the thing we need to think about, but what are our community clinicians telling us they are seeing and they're really struggling with taking care of on a daily basis? So those are just some big ones for us.
Thanks. Anybody else want to take that question?
I'll just add one in pharmacy land, the opioid crisis continues to be top of mind for everyone. How can we ensure that people are getting naloxone? How can we ensure that people are getting care that they need? How can we ensure that we're working with providers who are prescribing meds, sometimes appropriately, sometimes inappropriately, or there's a range of that. But how can we do that better? And then the tangential, all of the things that come with the opioid crisis too, right? So like you said, mental health, all of those mental health issues that come with that issue. The other thing I would say that in pharmacy land, just a focus of chronic care management. How can we do better at just not taking care of one patient, one prescription, but looking at patients holistically and being reimbursed for that?
Those are great. And I would echo, we have a big focus on mental health, particularly right now in children and adolescents. We've been seeing tremendous need there. As a primarily clinician-based PBRN, we do a lot with chronic disease management and have noticed a lot of desire for programs to be implemented and evaluated to help in that way. We actually have had a number of big projects that are led by NAC on self-measured blood pressure monitoring. And so, Christy, we can talk after. We have a lot of work in that area that we actually started right before the pandemic. And we had some ongoing with the pandemic. It was really fortuitous timing. We also focus on the opioid crisis, substance abuse, cancer screening, and then vaccinations, and having health centers be more effective and efficient with vaccination management and delivery of vaccines, and how we can work with our pharmacy partners in a really meaningful way. That's very important to us to try to do a better job with education and understanding where hesitancy comes from, and really trying to communicate solid health information surrounding vaccines.
Great. Thank you all so much for those really interesting answers. We do have a lot of questions here, so we're going to try to get through as many as we can, but there's one all the way that was submitted all the way back sort of towards the beginning of the webinar. I want to make sure we give that person a chance to hear the answer to their question. This question is for the PBRN that expanded in 2017 to collaborate with a pharmaceutical collaboration. I think that's you, Michelle. Did you have any pushback from your clinicians or members? And do you have pharmaceutical companies involved in supporting or sponsoring activities? I think there's a little bit of a conflict of interest question, and also just a kind of curiosity about how that works.
Yeah, so I'll try to answer very quickly, which is to say that the organization that we collaborated with was the State Pharmacy Association. So it was not a pharmaceutical company, it was the professional organization in Wisconsin. So it's the Pharmacy Society of Wisconsin. The equivalent for medicine would be the Wisconsin Medical Society. So just to be clear, it was not a pharma for-profit organization. Interesting question about pharma, though. We have chosen not to, at this point, work or partner with a pharmaceutical organization. Again, this goes back to your governance documents and really deciding what your PBRN is going to be about and what you're going to focus on and what are the projects that you care about. And so when we've had pharmaceutical industry come to us to conduct a project with them, we've gone back to that, we've gone back to our advisory panel, and with those documents, we've been able to clearly state that that's sort of outside of our scope and outside of our frame, and we feel very free and at peace to be able to do that. Could there be an opportunity to work with pharma? Yes, but we have not encountered it yet.
Great. Thank you so much. We'll go to the next question. It's a pretty interesting question. It it is, how closely do your PBRNs align with the original, and original is in quotation marks, AHRQ PBRN model? I'm going to start with Christy, if you.
I think probably what I'll say is, and yeah, I feel like I'm a little bit being like called out on, do I remember those original documents? That we certainly do far more community engagement and research education than the original PBRNs did. We also are more grassroots oriented. We're still a PBRN. Like we still are determining the effectiveness rather than the efficacy of treatments and screening tools, but it is different. And to hear Michelle talk about, being approached, we've been approached by people and chosen not to do studies that I think the original PBRN model would have probably endorsed or said was part of it. But for us, we've said that's not something that our internal structure is interested in. So I would say we're a little bit more of a, I don't want to use democratic because we don't vote, to Michelle's point, but we really do think hard about what's the mission and vision of our organization, which is locally informed, not as much federally informed.
Thank you. Anybody else want to add to that? Similarities to the original AHRQ model. Okay, well, we'll go to the next question. We'll let you think on that. So the next question is related to communicating with practices. Could you speak to the best balance you found when communicating with practices? Frequency of like newsletters or email updates, goals for visiting in person. How do you engage them but not overwhelm them? Joy, would you like to take this one?
Sure. I'll combine it with the original AHRQ model. So our PBRN started off very much in line with the model. We reached out to people already practicing. The primary goal of their practices to take care of patients and communities, and we grew from there. And I described that somewhat over the course of this webinar. So I think we still are very much in line, but we have other partnerships that help us now do what we do. So by partnering with NAC, by having funding, then we have other resources and abilities to reach out in a bigger way. And so NAC might have a CDC funded project, for example, our self-measured blood pressure program, and then health centers were invited in, but it came from the need at health centers, but the direction came from a CDC grant through NAC, then we partnered with them. And so it's still similar to the model, but a little different in how this is executed. And I'm describing that because the amount of contact depends on the project. Because we have this different structure and different ongoing projects, it's not the same as having a set number of health centers like I started with, where I had 10 and they were part of the PBRN. Now it's much bigger than that. And so if this is a large project, there might be monthly calls with the health centers, and these would be more led by the NAC team. And those calls or Zoom meetings could be addressing all sorts of different things, like the actual logistics of the SMBP program, or for other projects, it could be calls about data. How are you able to, if we're doing a program to help improve screening, how are you able to upload your data to show your screening rates month by month? Or if it's a hypertension program, we've had some different ones outside of the SMBP where we want really regular readings from the electronic health record. And we also are trying to gather social determinants of health data. And we might need more regular contact to help get that data transferred. But then there's a feedback loop to how to improve the collection of those data, such as surrounding social determinants. So I don't really have a direct answer. about how often we interact because of our shift from the original model. Originally, we had meetings once a month that were already built into our structure. And I would always be part of those meetings and talk with the regional directors of medical education, and we would incorporate our projects into those meetings, but that's changed over the last decade.
Jean, I just want to jump in. I know we're in a hurry, but I want to say that I just had this conversation at our statewide meeting. So at our statewide meeting, I asked them, how frequently do you want to hear from me? How do you want to hear from me? And what do you want to hear from me? So we're very user-centered in terms of that. And I'll just tell you the answers they gave me recently. I don't like to read my email. Are you going to send me an email? If so, what is the subject line going to say so I don't delete it? And is it going to have information in it that's going to change my practice? Then I'll read it. So that's what we're going to start doing this month for that feedback.
That's great. These are some great answers and great information. I think we have time for maybe one more question. We have about 3 minutes left. The question was originally about funding, but I think it's actually broader than that. They asked, what methods do you use to engage your school or university's leadership to get the internal support that you have? Quickly, we'll go around or is there someone who wants to take this one?
I'll say quickly, I always make sure that everyone in my school knows the NIHRFAs that talk about PBRNs.
For me, I'll just say that, when you sit in meetings and you talk about the things that are being talked about at the higher level. So right now at UW-Madison, they're talking a lot about recruiting in clinical trials, how that's so challenging, particularly for underrepresented, communities. And so then how do you frame a message around how you can support those initiatives? So again, very, very high level thinking, but trying to figure out how the PBRN can solve the university's problem.
Yeah, and I think just agreeing with things both Michelle and Christy have mentioned before in terms of saying mission focused and showing and being able to demonstrate how the work the PBRN is doing is advancing the mission of the university. And that's through meetings talking about it. Our advancement team has done some articles in AT Still magazine about what we're doing and what others in the AT Still Research Institute do. And we have other PBRNs at ATSU. And then while I like the way Christy said it, people before papers, but also publishing about what we do, presenting at national meetings. And our students present every year at the National Association of Community Health Centers, Community Health Institute. They submit their projects and they're peer reviewed, and some of them get chosen to present posters, and we have one oral presentation session where some get chosen to present, and they do such a great job every year that's always exciting for the health center partners. Health center partners have told me they've gotten some of their best ideas from our students, and for everyone at ATSU to see them shine like that, that's really helped. So that's part of how we started small and grew, but we're keeping the focus to continue to support the students so that they can grow as well. And I think that helps keep the energy and the dedication high.
Thank you so much. We're about to wrap things up. We're almost out of time. Maureen, is there anything else you wanted to add before we just talk about the upcoming learning series? And we have an evaluation if people would like to complete it.
No, I was just going to remind people of the evaluation that is up at the end, and say that this is one in the series, which is now up. And I wanted to thank all of our speakers for their dedication to their PBRNs and all the hard work that they have done. So thank you very much.
Thank you all. We could have the next slide, please, in case anyone would like the QR code. And if you'd like to evaluate this webinar, you can do so here. We hope to see you online for the next 2 webinars. If we didn't get to your question today, we'll either post answers online or answer them on one of the upcoming calls. Thank you again. Thanks, everyone.